بس- بسم الله الرحمن الرحيم. Hypersensitivity pneumonitis, what's called also extrinsic allergic alveolitis. Hypersensitivity pneumonitis is a cell-mediated immune reaction to inhaled antigens, and patients must be sensitized by an initial exposure with subsequent re-exposure leading to acute or chronic hypersensitivity pneumonitis. The acute form often occurs after exposure, short period exposure to a high concentration of antigen and is usually reversible, but the chronic form typically follows a period of chronic exposure to a low antigen dose and is less reversible. The cause of hypersensitivity pneumonitis, it is type 3 and type 4 hypersensitivity. It is not an atopic disease and is not characterized by a rise in tissue eosinophils or IgE. So it's not type hyper 1 hypersensitivity. It is type 3 and type 4 hypersensitivity, and there is no history of atopy and no rise in eosinophils and no rise in immunoglobulin E. Examples of antigen causing uh, example of antigens causing hypersensitivity pneumonitis. Microbial antigens examples are Thermoactinomyces vulgaris, when exposure to moldy occur when there is exposure to moldy sugar cane, and the name of syndrome in that case is bagasosis. If the microbial antigen is Thermoactinomyces saccharoi, the exposure will be or occurs after exposure to mushroom compost, and the syndrome name is mushroom worker's lung. If the antigen is Aspergillus species, it is due to exposure to moldy hay, and the syndrome will be farmer's lung syndrome. Other antigens include animal proteins, such as avian proteins, when there is exposure to bird droppings or feathers, and the name of syndrome is bird fancier lung. If there is urine or serum or pelts animal antigens, there is exposure to rats and the gerbils, and the syndrome name is animal handler's lung. If the antigen if the antigen is chemical, such as isocyanates, the exposure after exposure to paints, the syndrome will be chemical workers lung syndrome. Clinical picture of hypersensitivity pneumonitis. Acute form, there is dyspnea, dry cough, and there are systemic symptoms such as fever, arthralgia, myalgia, headache, occurs 4 to 6 hours after exposure to antigen. Examination will be by auscultation of the chest, revealing inspiratory crepitations. The chronic form will be same as interstitial lung disease. Investigations. Radiology investigation will reveal infiltration on chest X-ray or CT. Investigations for hypersensitivity pneumonitis. Radiology investigations include chest radiograph. In acute hypersensitivity pneumonitis, there is diffuse small 1 to 3 millimeter nodules or infiltrates, sometimes ground glass change, apical sparing, normal in up to 20% of cases. The high resolution CT revealing patchy or diffuse ground glass change and poorly defined micronodules, areas of increased lucency or mosaic attenuation, and large enhanced on expiratory HRST occur due to air trapping from bronchial involvement. Both chest X-ray and HRCT appearances may quickly normalize following removal from antigen exposure. Imaging in chronic hypersensitivity pneumonitis, chest X-ray typically there is upper and mid-zone reticulation, reduced lung volumes. In the HRCT, there is diffuse centrilobular nodules, ground glass change, mosaic attenuation from air trapping, and maybe honeycombing from traction and traction bronchiectasis, which may mimic appearances of UIP, although upper loop predominance is typical in hypersensitivity pneumonitis. Pulmonary function tests typically there is restrictive pattern with reduced gas transfer and lung volumes, and mild obstruction is also sometimes observed, may be normal, and blood gases may reveal hypoxia. The blood investigations, the acute hypersensitivity pneumonitis is associated with neutrophilia but not eosinophilia, and inflammatory markers often increased. Serum antibody IgG precipitin results are presented either as an ELISA or as a number of precipitin lines, referring to the number of different epitopes to which an individual responds. Precipitins to organic antigens are found in 90% of patients, but are also present in up to 10% of asymptomatic farmers and 50% of pigeons breeders, and precipitin levels often fall in the absence of ongoing antigen exposure. So that antigens will be positive when there is exposure and will be absent or will be absent when there is ongoing antigen exposure. If the exposure is not present, there will be no antigens or precipitins. The bronchoalveolar lavage, lymphocytosis, often more than 50%, is the characteristic finding, particularly in the setting of ongoing antigen exposure, but is not in itself diagnosed and may be found in asymptomatic exposed individuals. Transbronchial biopsy or surgical lung biopsy may be required in cases of diagnostic uncertainty. Transbronchial biopsy often fails to provide sufficient tissue or adequate histological analysis. Inhalation antigen challenge may be unpleasant and is not recommended routinely. Management of hypersensitivity pneumonitis. The main management or the most important management of hypersensitivity pneumonitis is avoidance of suspected allergens. If completely removal from antigen is unrealistic, such as in farmers, measures to reduce exposure may be of benefit, such as respiratory protection with high performance and positive pressure masks, avoidance of particularly heavy exposure, improved ventilation and use of air filters or drying of the hay prior to storage. Cortisone sometimes used uh, and it is frequently used, although there is a lack of randomized controlled evidence to support this importance in management of importance of use of corticosteroids in management of hypersensitivity pneumonitis. The prognosis is highly variable. Prognosis is usually excellent following removal from antigen exposure in acute hypersensitivity pneumonitis, although progression to respiratory failure and death may very rarely occur after short-term exposures of very high intensity. Recurrent episodes of acute hypersensitivity pneumonitis do not necessarily progress to chronic HP and fibrosis, and chronic HP may develop in the absence of previous acute HP episodes. Development of chronic HP with ongoing exposure may eventually lead to core pulmonary and death, although again this is variable and many proteins and many patients do not exhibit disease progression despite chronic exposure. That's all. Thanks.